So this presentation is about esophageal stenting. We'll cover first indication, then we'll explain what are the types of stent we have in our armamentarium and how to select them. So indications, the major indications are, according to guidelines, benign refractory strictures or malignant strictures, and lastly, leaks and perforations. So regarding benign strictures, our European guidelines, the latest, do not recommend the use of stents as a first-line therapy in the treatment of benign strictures, but just as a treatment for refractory strictures. They recommend fully covered self-expandable metal stent as a type of stent preferred over partially covered stents or other kind of stents. So another indication, malignant stricture, and this involves our colleagues here present. So before surgery, should we stent? This is a study, a multi-center European study based on propensity score analysis, and we can see two of the outcomes. They are postoperative mortality and morbidity. They're not significant, but they are higher in the group treated with a stent before surgery. Whether if you look at the bottom, we can see that R0 and the time to recurrence rate were worse in patients with the self-expandable metal stent placed before surgery. In this graph, we can see the survival, and the upper curve is the one of patients treated directly with surgery without the stenting, as well as we can see here there is significance, and the 3 years overall survival is higher in patients operated without stent. This is another study, again supporting the outcomes. The survival is better in patients that directly go for surgery. So the guidelines do not recommend the placement of a stent as a bridge to surgery or before preoperative chemoradiotherapy because it's associated with a higher incidence of adverse events. Another setting in malignant strictures for palliation. Should we place a stent or not? Well, we can see here the green is the esophageal score of patients treated with a stent. It immediately drops, and in red we can see the patients treated with brachytherapy. So the stent is more effective in the first days to treat the dysphagia, but if we see with weeks and months, the dysphagia score is higher in the patients treated with stent compared to brachytherapy. This study is quite old, 20 years ago, but published in Lancet, and so current guidelines recommend basically that we have to estimate, in case of a malignant stricture, the prognosis of the patient. If the expected survival is more than 6 to 8 weeks, it is better to treat it with radiotherapy as a palliation for dysphagia, plus or minus chemotherapy. And if the survival is low, we can go for stent placement. In case of benign strictures, and we will cover more in detail the SEMS, self-expandable metal stents, which are the most widely used. So their characteristics, they have radiopaque markers and wires at the flanges, which make the removal easier. They gradually expand after placement within 24 to 72 hours. There are different sizes of the body, the flanges, and the size of the delivery catheter, different mechanism of release, and they differ for the covering status as well. These are 3 types of stents, which differ for the size and the relationship between the body and the diameter and the flanges diameter. The standard on the left is placed over a wire, might be proximal or distal release. Then the Agile, where the diameter of the flanges is slightly lower. They are placed through the scope, but you need therapeutic gastroscope because you need a big working channel. Largest diameter is 18 millimeter. And you can place them under endoscopic view, therefore reducing the time of fluoroscopy. They're also reconstrainable. And then there is another type, the cervical, where this proximal flange is shorter, as we can see, compared to the distal one. So they're useful in the hypopharynx, so in the upper esophagus. These are examples of 18 millimeter stents. So here we can see the standard stent. So the size of the flanges varies depending also on the brand. We can see here, for example, for an 80 millimeter stent, 26 millimeter diameter of the flanges. Here the cervical, same size, but the proximal flange is shorter. This is another brand, and we can see that the two flanges are different. So 23 millimeter and 25 millimeter diameter. And this is the Agile, so 18 millimeter against them. And there the flanges are both 23. So we have to consider, of course, size and location to select the best stent for our patient.